Okay, so can you see the presentation okay? Is that coming up on your screen?
Yes, we can see.
Yeah, we can see that this from Teams.
Lovely. Okay. There's only 2 people here in the room in Boston. I seem to have a problem with the camera. I wasn't sure if the microphone was working as well, but it seems like it is. But,
what I think it is, I think the camera's just set up on the other screen. It's all right if I just quickly come out here for a sec.
yeah, okay.
So it just
I've still logged into my own account, so that's where the presentation is.
So what I think it is, I think the settings are just set to the wrong camera. Sorry, we thought you were doing it from Lincoln today. Not sure why.
I work here in Boston, so I tend to.
That's fine. Right, so that should be fine.
It worked when I got here. It was set up obviously on a generic account.
Yeah,
it seemed to be on.
Well, it's coming up on that one. I mean, obviously they can't see you on that.
That one's fine.
Yeah.
At least we're. Yes, we're.
Let's say that it wasn't working now.
You can see that somebody's here.
Right, there you are.
All right, I'll do that then.
Sorry about that.
No problem. Right, so sorry about the slight delay. Can I just check what time are you expecting the next speaker? And you've got somebody doing an endocrine session as well, have you?
Yeah, I think it should be. I think at 3 o'clock.
3 o'clock, right? So just between 2 and 3. Right, let's get started then. So I'm going to do a session on ethical issues at the end of life, and I'm doing this through a series of case studies. So these are real cases that I saw here in this hospital, 1 or 2 in the community. And I'm going to look at those and then think about the ethical issues and so on that arose. Unfortunately, whenever you talk about medical ethics at the end of life, people get really excited about about assisted dying. And that's probably one of the least interesting kind of aspects, because that's all theoretical at the moment. We don't have that in this country, whereas all of these issues do come up. So these cases touch on artificial nutrition hydration issues, on an ICD and implantable defibrillator and what to do with that, sedation, non-invasive ventilation, withdrawing and withholding treatment. There's a bit about discharge from hospital and about whether or not somebody wants to be readmitted, and then DNACPR and respect. So I'm going to try and touch on those things, but it is a case studies. It's not just going to be me talking for an hour, 45 minutes. So I will need interaction. So I appreciate that's difficult in the sort of hybrid setting that we've got. And unfortunately, I was hoping there'd be a room full of people here, because that makes it slightly easier. So you guys are in the hot seat. But I do need everybody who's online to be willing to kind of unmute and shout out when you've got something to add. So there are questions that come up through the presentation. So if we look at the first case, 75-year-old woman, bilateral middle cerebral artery infarcts, has been in hospital for 7 weeks. Now, as you may know, if you've had bilateral infarcts hitting the same territories, then you haven't got anywhere to kind of take over those functions. So the recovery from those sort of strokes is not great. So she's been in 7 weeks. She's still GCS4, can open her eyes, but no other response, no improvement in that time. NG fed since admission, as you know, we put an NG feed in early and use that from the start, but you then get into the position of where do we go from here. And she's had recurrent chest infection, so she's had 3 courses of antibiotics during the admission, been in 7 weeks. And she was referred through to our palliative care team to plan discharge. So what are the issues around discharge that immediately jump out at you? What are the issues that we're going to have to think about?
Look after her.
Okay, so there's something about where she's going to be and how can we make sure that she's getting adequately looked after. Any concerns about how we manage that?
Preferred place as per the family.
Okay, so there's something about what would she want, and because she's had a sudden stroke, a devastating stroke, she's not able to tell us, and the likelihood is that she hasn't told us up to now because she hasn't known that this was coming. This wasn't a slowly progressive illness. Anything else?
Carers. Any prior carers.
Yeah, so something about who's going to be providing the care, family and their input. Any particular concern about her medical care that jumps out?
Of being how long is the NG feasible for?
Yeah, so that's the big problem here, isn't it? How do we manage an NG feed in the community? Can you do NG feeding at home? Okay, can you do it in a nursing home?
Probably, yeah.
Possibly one or two, but not many. Whole Beach will do it, but I don't think there are many that will do it. And what might be the first problem that comes up when you've got an NG feed? Okay. I'm happy if you're online, if you want to shout out. What happens to NG tubes after you've used them for a few days or a few weeks?
Displacement, aspiration.
Yeah. Okay. So they get displaced and they need resiting. If you're using a feeding tube, how do you resite it? Well, you've got to get check X-ray, haven't you, and make sure it's in the right place. Before you use them, you're supposed to aspirate to check the pH. Can you aspirate them after they've been used a few weeks? You stop being able to get anything out of them, don't you? So they're fine when they go in, but after a while they get furred up and you can't do it anymore. So what do you then do? If you can't aspirate, can you use it or not? Could it have been displaced? Might it be in the lungs? If you're not careful, what do you do? Here you send them for a check X-ray, but are you going to keep sending somebody in every day or every few days whenever there's a problem for an X-ray? So in practical terms, you can't really do it. So what do you do for long-term feeding and something like this?
Peg.
Okay, so a peg or a rig, sometimes we do it radiologically. Is it appropriate to put a peg tube into somebody like this?
She's got a good functional status.
Okay, has she? So that question was, if she's got a good functional status, then maybe it is. What's her functional status?
She's breathing now.
GCS4, so she's unconscious.
So not active.
So is it appropriate to put a peg into somebody like that? So where do we go?
Planning.
Okay, so we're a bit stuck, aren't we? And it's difficult to know kind of where we go from here. So there's that whole stuff about where's the right place to look after her, how can we deliver her care, how can we carry on feeding her and giving her nutrition and hydration, and if we can't, that looks very different and we need to kind of have that conversation. So we were referred, could you discharge this patient for us because we're stuck? And the answer is, no, we probably can't. We need to think a bit more about actually where are we going here and what we're trying to do. So there'd been a decision made not for any more IV antibiotics. She'd had 3 courses of antibiotics in the 7 weeks she's been in. A week later, developed a chest infection and she was starting on IV antibiotics. That is what happens in hospital. It happens all the time. It happens with all of our patients that we have decisions made and then a week goes by, nobody reads back. Nobody kind of is aware of that. That kind of organisational knowledge isn't passed on because the teams change. They might move to a different ward because they need a side room or whatever. And then it'll be one of you guys out of hours who is asked to kind of make a decision, and you kind of make a decision on the basis of what you're seeing in front of you. And that handover about what decisions have been made already, we don't read back and don't look properly. So that happens all the time. So she started on IV antibiotics. Did the consultant the next day say, no, we've said we're not going to do this? No, we've started it, we'll carry it on. Oh dear, we're not getting anywhere. Switched to second line antibiotics. So she was then on meropenem. So we're kind of escalating treatment. This is a 4th course of antibiotics and now on second line meropenem. So there is enough here to say this lady is not doing well. Why does she keep getting chest infections?
Aspiration.
Yeah, so we're filling her stomach with liquid food in somebody who is GCS4, and therefore anyone less than about GCS8 is deemed not to be able to protect their airway. She's lying flat, we're filling her stomach with food and she can't protect her airway. So we're causing that. So we're actually doing harm. Now, obviously, if we don't feed her, people don't survive. But if we do feed her, we're also doing harm. So we've got to kind of weigh that up. What the consultant told me was that they were struggling to get the sons to accept that this lady wasn't going to recover. And so I met with the 2 sons to discuss it further. And actually, that conversation was much easier than I thought it was. Maybe because they'd already kind of made a start on it and they'd come to terms with it. Maybe just because it was sort of discussed in a slightly different way, or, you know, sort of listened to them first of all. But they were actually fully accepting that she wasn't going to recover from this. And they'd been here before. So their father had died of dementia and pneumonia. So a sort of similar situation where he couldn't swallow safely, and people with dementia tend to die of chest infections in the end. So he'd been down this route before, and they had had a similar sort of set of they had had similar conversations about him. So there was then a discussion about whether or not to continue the NG feed. So I'll come to people online. Can you tell me, what are the pros, first of all, of carrying on NG feeds? What are the benefits?
Nourishment.
Okay, so it's to optimize her nutrition, absolutely. Why?
To keep her alive.
Okay, so to potentially prolong life, and that's not an unreasonable goal. Like, we are doctors, that is kind of what we're part of what we're trying to do. So there is something about that. In this situation, is prolonging her life of benefit? Okay, so it's questionable, isn't it? Certainly at best. And some people would say, you know, they want to hold on to life at all costs. But here you would say that she objectively has very little in terms of quality of life. Now, it's very difficult for us to assess somebody else's quality of life. But if somebody is unconscious, then, you know, it's a reasonable thought process to go through. Is it prolonging her life? Or are we shortening her life by giving her a next chest infection?
Shortening her.
Yeah, so it's not clear, is it? I mean, it's 7 weeks since the stroke, so if we hadn't started the feed, she would have died by now. So we've clearly kept her alive this long, but at this point, with her 4th chest infection, now on second-line antibiotics, are the feeds doing good or are they doing harm? And I think you could make an argument that they may be doing more harm than good. Okay, what are the cons? What are the downsides of carrying on the NG feeds?
Repeated chest infections due to aspiration.
Okay, yeah, so we talked about the aspiration risk and recurrent infections. Anything else?
Need someone to take care of it.
Yeah, so there's a problem about the decisions that we're making on her behalf. So we're making a decision here about where she needs to be, which essentially is in hospital with these recurrent infections, with the risk of dislodgement of the tube and all of that sort of stuff. Then we're essentially saying that we're going to keep her here in hospital for the rest of her life. So again, that might not be where somebody would want to be. I know if I went around and asked you lot, because I've done it before in big groups, almost nobody says I want to die in hospital on a drip. Okay, we all have different ideas as to where the best place to be is, but it's very rarely kind of on a medical ward with needles being stuck in. There are complications and downsides. It might be uncomfortable having the tube in, might be causing some distress, although she was probably too unrousable to notice that. But if we're using it, to extend life, I think we've argued that it may or may not be the case here, and is that a benefit anyway? Sometimes people say, well, actually, you could carry it on in order to keep her comfortable. And there is a thing about, you know, is starving to death, if you use sort of emotive language like that, is that a real negative? I think you could say that we have drugs that help if you're agitated and distressed, and midazolam and other things like that have got evidence behind them of helping in these circumstances. Liquid food through a tube probably doesn't have that evidence. And when we've looked at, there's a Cochrane review about artificial nutrition and hydration, and it doesn't really have any evidence to suggest that people are more comfortable or have fewer symptoms if we're feeding them artificially. So it probably doesn't do them any good and may do more harm. So a decision was made to stop the NG feeds, and we agreed discharge to a community hospital for end-of-life care. Okay, family very much on board with that. And there was a decision not to refer back to acute hospital for further antibiotics when she gets the next chest infection. And it's not if, it's when. It'll come again. She's still being treated for the current one. When she deteriorates, we're not going to transfer her back. All sounds very reasonable. The questions I got from the medical consultant in the middle of a busy ward well, is it ethical to do that? And does it require a court order? So again, I'll come to those online. What do you think? Does that sit comfortably with you to go down that route?
No, it doesn't require.
Okay.
I think it's fair enough.
Yeah. Okay. In what circumstances would you require a court order?
There's unexplained reason for this.
Okay, so you might do if the family were very much in disagreement, or you wanted to stop things and they were saying no. Essentially, these things are medical decisions, but ultimately very difficult to sort of take a tube out of somebody if the family are dead against it. So that might require court of protection. But the other circumstances is persistent vegetative state. And the argument that was put to me is, what is the difference between this patient and somebody in a persistent vegetative state where they've been stable for many years? Obviously, there are examples of this where people have had that and have been fed through a tube. The answer to that is this isn't a persistent vegetative state. That's a very sort of specific thing. And actually, the law has changed on that now to say that where we've got these circumstances where there's an agreement, you don't need to go to court for that either. Yeah, it's difficult when you're sort of faced with that argument from somebody to say, but that was coming from a personal position from the individual that they felt uncomfortable with stopping active feeding in somebody. Having kind of come at this from a palliative point of view, I feel much more comfortable with that, and I think people generally are kind of more on board with these sort of withdrawing and withholding treatments. The ethics of it are there is no difference between withdrawing a treatment, which is what we're doing here, and withholding it in the first place. So if we decided at the outset, this lady's not well enough, she's not going to survive, we're not going to put a feeding tube in, as we decide all the time for end-of-life care patients where we think that they are dying and they're not eating, but they're not eating because they're dying, so we don't put tubes in to feed everyone. We're making that decision. Here it feels different because you're taking something away as opposed to not starting in the first place. But actually, ethically and legally, there is no distinction between those two. And that's really important to remember that, because if we get into a position where we don't want to start a treatment in case we have to withdraw it and it feels different to withdraw it, the danger is that you start to get into a position where you don't do things in the first place. And you're better off, your chances of recovery from a stroke, for example, are better if you optimize nutrition from the outset. As it turned out, that didn't work in this case and the lady didn't recover. But we don't want to get into a position where we're not starting a treatment because we may have to withdraw it. So it's important to remember that distinction. Okay. I'm going to crack on because I know that we're sort of fairly short of time and these things do take a little while to discuss. So I've got an 83-year-old woman with an ischemic foot, which is necrotic. She's not for surgery, she's got congestive cardiac failure and she's not fit for an operation. Eating and drinking small amounts. Relatively stable, and again, been in 4 weeks. My general cut-off is if somebody's been in more than 3 weeks and they're not getting better, despite your best efforts, then they're palliative and time is looking quite short. There are obviously some differences to that, some situations that sit outside of that, and there are people who slowly recover. If they're showing recovery, that's fine. But if you're not getting better and you've been in hospital for a month, you're not getting better. We need to think quite carefully about what we're trying to achieve. So she was planned for discharge to a nursing home. Good, okay. What considerations do we need to make for discharge? Welcome, obviously got a new person just walked into the room, so I'm afraid we're going to pick on you now. What do you think?
Considerations you will make. The first thing is to make a decision of what level of subsequent care you want to make when a person is going to a nursing home, and what level of the subsequent decisions in case the patient deteriorates. What's the plan? So it involves an advanced, advanced planning. Yes, an advanced planning with the patient or with the relatives or whoever the patient is designated to make the decision for them in such cases.
So we need to check with the family, assuming it's the family, and get them on board, make sure that we've got a clear plan, and we need to know what her escalation status is. When you say if she deteriorates, what you mean is when she deteriorates, because she's got an ischemic foot, which is necrotic. She's going to die of this. This is a terminal event.
Yes.
Her prognosis is weeks, and she's already had 4 of them. So her prognosis is relatively short, and she will get an infection which is overwhelming, and she will die from it at some point. So just take a step back and remember that this is a lady who is dying. And then what are we going to do when that happens, which is inevitable? When the inevitable happens, what are we going to do? And the most important thing is, does she come back into hospital? Okay, and that's partly down to her wishes and the wishes of the family. But it's also about what are we going to do if she does come back into hospital? What have we got to offer? We can give antibiotics, but you can't cure a dead leg. You can't sort of treat that infection. It will get you eventually. You can clear the bloodstream and you can make people feel better for a short period of time, but the seat of infection is still there and is untreatable. You can't get antibiotics into it. You can't sterilize it. You will get resistant bugs and they will die eventually. So you can prolong that process at best, but that's as much as you're going to be able to achieve. So being clear on that, and also maybe wording it differently, but being clear with the patient and their family as to what we can and can't achieve and what the benefits of coming back into hospital might be. Okay, so what happened? She started to deteriorate, as you would expect. No longer eating and drinking. It takes a little while to get somebody to a nursing home. So while this was going on, she started to deteriorate. Not eating and drinking, became more drowsy, dropped her blood pressure, still on lots of medications. Okay, cardiovascular arteriopath, therefore lots of cardiac type drugs. And her consultant was started on IV fluids. It's obviously one of the surgical team. And she started to develop peripheral edema, as you would expect in somebody with heart failure, where you're now putting IV fluids up. So what do we manage? How do we manage that? And again, I'll come to you guys online.
Family discussion.
How low is the blood pressure, was that?
Family discussion.
Oh, family discussion. Sorry, I misheard you completely. Yeah, so there's something about getting the family involved as to what we're going to do and where do we go from here?
We need to decide about the level of escalation.
Yeah, okay.
Because it's a tricky situation. She has low blood pressure, but we can't give fluids. And
Yep.
if we give fluids, she's going to be fluid overloaded, so we can't take the fluid out. So
Yeah, okay. Does she need any more fluids?
no.
Okay, so she's full of edema, she's got a heart failure, she's got enough fluid on board, it's in the wrong places, she can't handle it anymore, she's too poorly to keep it in where it needs to be. So putting more fluids up isn't the answer. We certainly can help because she's on diuretic, and we'll get rid of that. She's on beta blocker and spironolactone. Oh, sorry, yeah, so things that drop the blood pressure. So we can stop all of those. That's relatively straightforward. Let's kind of optimize treatment, usually by stopping things. She's too drowsy to swallow them anyway, so we're not really losing very much. So we can do that. The difficulty I had here is that the vascular consultant then disagreed and said she's not drinking, she needs fluids, put fluids up. Fluid balance, fluid management, this is my thing, I need to do that. Okay, so you're then in a difficult position where you're kind of pulling in different directions and trying to work out what the sort of best outcome for the patient is. Ultimately, I wrote in the notes, stop the fluids, and they was happy to do so. But it's that taking responsibility for that. And you might find that as medics, when you're kind of on the medical kind of registrar rota and then sort of further on in your careers, that sometimes you have to take the responsibility for saying, I think that this is the right thing to do. I'll kind of take that, and then you can move things forward. But yeah, quite difficult when you've got kind of difference of opinion as to what's the right way forward. The problem with the IV fluids is, again, we're keeping her in hospital. It's not helping. It's not going to change anything. She's still going to die of sepsis fairly soon. The dropped blood pressure may be just a sign of the ongoing sepsis. Do you carry on with the antibiotics? Again, that's a discussion you can have with the family. Kind of depends how much benefit she's got from it. If she's deteriorating and becoming more drowsy, we're probably at a stage where that's no longer adding very much. Okay, but we did manage to kind of get them to agree, and then we could sort of get her out of hospital. Okay, so next case is an 82-year-old man with end-stage heart failure. He's in the coronary care unit, no improvement despite maximal therapy. So he's on everything that you can think to throw at somebody with heart failure. He's exhausted. He's got massive edema. He's got ascites, abdominal distension, short of breath, needing all care, needing assistance. He can stand and transfer, but with somebody helping him. And he's got an ICD in. He had several shocks during admission for VT and torsades and other self-limiting runs of VT, and the ICD was put in. All of this happened when he was on a dobutamine infusion to try and sort of help with his heart failure. So he's got a significant cardiac history, and he's now got this machine in that will shock him. His wife can't manage him at home. She's equally elderly and quite frail and can't manage him at home. So the plan was to transfer him to a community bed, so palliative care beds in the community hospital. So here in Pilgrim, you've got a choice of Skegness Hospital, if people are near there, or Louth Hospital's got some palliative care beds. The Johnson Hospital in Spalding has, and you've got Holbeach Hospital down in the Holbeach area. So you've got a few places around that have got hospital palliative care beds. Obviously, here in Boston, you've got the Butterfly Hospice. In Lincoln, you've got Gainsborough, so you can send people up to there. There's palliative care beds there. There's a hospice in Newark, so if they're that way on, you can do that. Obviously, I work at St Barnabas Hospice in Lincoln, so that's for the people of Lincoln. If people are further down towards Grantham, they've got a hospice in the hospital there. So there's various palliative care beds around. All of them have similar kind of referral criteria and amounts of treatment that they can offer in a nurse-led unit with GP sort of support, apart from St Barnabas Hospice in Lincoln, which is a consultant-led unit. So we can do IV antibiotics and fluids and stuff like that if we choose to. Okay, so what are the issues that need to be worked through for him?
Probably dispatch off the defect.
Yeah, so he's got an ICD in place, so we need a plan for that. How are the community hospital going to enjoy that as a part of the referral process?
No.
They're going to say no. No, got no idea what to do with that. Don't know how to manage that. We can't handle it. You need to sort that out. Okay. When you say we need to turn it off, what process do we need to go through?
I think we'll have to discuss it with the family to see that that probably it's better to, as we reach that we are going on the palliative side.
Yeah,
it's better to like turn off just the defect part of it.
Okay. So there is something about the patient as well. The patient is sort of conscious and able to be involved in discussions here, and he has capacity. They need to understand what's happening, because often heart failure isn't seen in the same light as, say, an advanced cancer. Everybody knows that if you've got cancer and you can't treat it, you die from it. Heart failure is often seen as something that you live with, despite the fact that, as you know, the prognosis is worse than most cancers, as you've heard hundreds of times. So there is something about kind of what we're going to do with this ICD. What is his prognosis? What's going to happen here? What's the trajectory that we're expecting? And then again, that question about whether he comes back into the hospital as and when he deteriorates. What more has the hospital got to offer? Okay, so I had a discussion with the patient and his wife. They understood he's dying. They understood that time is quite short, so they're on board with that. That's fine. Keen for transfer to the community hospital near home. So far, so good. We're on track. Able to state that he wants his ICD to remain active. Oh dear. That might be difficult then. He did agree that when he got to the point where he could no longer express a wish, so when he was unconscious, at that point, he didn't want it to carry on shocking him while he was dying, so he could have it deactivated then, but he didn't want it deactivated while he was still conscious. Community hospital, not happy about that as a plan, very anxious about it, questioned whether he understood the implications. So have we done our job properly? to which I was able to say, well, I did it myself, I did my best. And the GP actually came in to review him in CCU. So this is a GP who was looking after him in that community bed, and he came up, you know, they're from an hour away, and they came up to see him in the hospital to sort of go through this. Now, you don't get that sort of service very often. I don't imagine we'd get it these days, but at the time, a few years ago, maybe things were slightly less fraught than they are now. He came up and saw him himself and reviewed him and came up with and discussed it with him. So there is also a question of what does an ICD actually do when somebody's dying? So they are programmed in different ways, but this one and most of them are programmed to give 6 shocks and then stop. So they don't just carry on shocking indefinitely in somebody who is dead. Okay, they will shock up to 6 times. If that's not working, then they stop at that point. The difficulty is what happens if they work. So you shock, you get partial recovery, the heart starts up again, carries on for a minute or so, and then stops again, or goes back into VF or VT, whatever, and then it shocks again, and it gets him back again, and you have this sort of prolonged dying process. I have seen it where somebody is dying and keep jerking because the thing keeps shocking them, gets the heart started again, and then it deteriorates and it stops again, and it just keeps shocking them. And it's a really difficult kind of position to be in. So the solution to that is a magnet. I'm sure you're aware, on the resource trolley, there is a magnet stuck on the side of each of them, and you put that over the box, and that will temporarily incapacitate it and stop it. So you can use that. So a magnet went with him, clear instructions given, and discussion between cardiology and the community hospital. Quite a lot of involved kind of decision making and discussion going on to make this happen. Cardiology technician was organised and ready to be able to travel down and deactivate it as and when we got to that point. And it was transferred with the ICD still active. He became more confused, now lacking capacity, but still awake. And his wife was adamant that the ICD should still remain active while he's awake. What does awake mean? I don't know. Maybe he has his eyes open. He was able to kind of respond, but he clearly was confused and drowsy and didn't have capacity. So should we overrule her?
He did make decisions while he was fully conscious and had capacity that he wanted it deactivated.
Okay. Did he want it deactivated at this point or when he was unconscious?
The grey area, isn't it?
Tricky, isn't it?
Yeah.
Yeah. I think he said that he wanted it deactivated when he was no longer conscious. Oh, at least that was the implication of what he was saying. But you're right. I mean, you could, you could squeeze through the middle of that kind of decision making, couldn't you? And it's not easy. Okay. Is it the same as the DNACPR decision? Can we just say it's medical treatment and we're saying no? Straightforward, is it? Not straightforward, because to go and do it, to turn it off, could be seen as an assault. Okay, this isn't a decision we're making as a treatment. You clapped in front of me, I decide whether I'm going to do anything about it or not. This is something that is internal to him. You could argue it's his property, it's his body, and we're kind of needing to interfere with it in order to turn it off. So it's not quite the same as just saying this is a medical treatment and we're gonna say no. So it again comes back to a best interest decision, and the best interest decision, if he lacks capacity, is what do we think he would have wanted, and his wife is telling us he would want it to carry on. It's very difficult to then say, actually, you know what, we're going to overrule that. So what happened in practice is that it remained in place until a couple of weeks later when he lost consciousness and he became kind of unconscious. At that point, his wife agreed, magnet was put on, technician came out to deactivate. That was 2 days later, so he had a magnet on for 2 days, but you know, it was in place. And then he actually died a further 18 days later. So it was quite a prolonged process, and we were able to kind of do that. But luckily, at no point did he have any actual shocks, and he died peacefully in the community hospital where he wanted to be. So we did get there in the end, but it's quite a process to go through. Okay, case 4 is an 81-year-old man with a glioma, and he was treated with whole brain radiotherapy. Following that, he became increasingly confused and aggressive. He was able to talk to us. He could sing, and we had all the old classics, Roll Out the Barrel and Knees Up Mother Brown, echoing around the ward. He was doing all of that, but very uncooperative with care, wouldn't let you anywhere near him. If he was refusing all his medications, he was hitting out, he was verbally aggressive if you came too close. You could stand at the edge of the room and talk to him about the football, he'd be fine with that. But if you started to talk to him about, you know, do you want to have a drink? Can we come and change you? Can we kind of, you know, can we provide any care? Do you want us to put some antibiotics up? Can we send you for a scan? Any of that, he'd start getting aggressive. He'd throw anything that was in reach. He was refusing all food and drink. Nursing staff quite distressed because they couldn't manage him and they couldn't care for him. And that was the bit that was distressing them. He was dirty, he was in a dirty bed, he needed to be changed, and they couldn't do that because they couldn't get near him. So how can we help the nurses? Is it appropriate here to sedate him? And if so, what are we sedating him in order to be able to do? Can we sedate him to treat him? Can we sedate him for scans and investigations? Can we sedate him for food and fluids because he's refusing all of those? Can we sedate him to change his underwear and clean him up? What can we do and what can't we do, do you think?
Sedate him to make him comfortable.
Okay, so make him comfortable. So we're saying that we can sedate him in a limited way in order to make him comfortable. I think you could argue that he was happy and kind of okay as long as he didn't interfere with him too much. He was able to kind of be alert and awake. He was, you know, he'd have a conversation with you. So you'd be taking something off him if you sedated him from here on as a sort of terminal sedation until he died.
At this point, do we know, or the decision as a discussion does it need to be made on what level of treatment do we plan to offer down the line? Do we think the reason for the agitation is a something acute or is it directly progression of the glioma?
Yep.
After discussion with the family, and then once the ceiling of care, what we expected medical outcome is, then can affect the decisions to be made.
Okay.
If we think we're going towards life prolonging care and we think certain steps can still be taken, then the rationale for doing the said chemical sedation to give him appropriate food treatment can be done. If we do not think that further treatment will be beneficial, then we may ask ourselves, what is the aim of sedation? Is it beneficial for the patient or just to make us more comfortable?
Okay, so would you be happy if we decided that glioma is on his radiotherapy, the next thing would be a course of chemotherapy? We could sedate him, you know, for 16 weeks to get him through a course of chemotherapy. Or could we sedate him in order to send him for a scan to see what we're dealing with and then kind of take it from there? Yeah, so you can see how kind of it gets difficult, doesn't it, as to kind of where you draw that line. If we'd sedated him to send him for a scan, what's the scan going to show us?
Says with the surrounding edema that can respond to treatment, and then.
Okay, so it might be edema, in which case we could give him some steroids. How long do steroids take to work?
So
probably a bit longer than that, 4 or 5 days really before you can do a proper response to them. So could you sedate him for the best part of a week to get him through a scanner and then give him a course of steroids because he's not going to accept them? So yeah, steroids aren't just a one-off, are they? They're going to take a while to do all of that. What else? So you might find edema. What else might you find? Yes, the disease might have progressed in that time. So despite radiotherapy, his disease progressed. Can we do anything about that? Probably not. Okay, what else do you get? A patient like this. What's the most likely diagnosis here as to why this has suddenly happened? It's 81, I think.
Is it a delirium?
Possibly, and you could argue there may be an infection going on here, but I don't think there's anything particular to suggest that. No, I mean the question is whether he's got radionecrosis following the radiotherapy, and so inflammation and necrosis of the brain, which is well recognised as a side effect of whole brain radiotherapy, which may kind of recover in time, but we're talking about weeks down the line. So that's quite a serious complication, really. And again, there's very little you can probably do about that. Steroids might make a difference, but probably not. So the question here is there anything reversible here that we could do anything about? The only thing is probably steroids, and steroids aren't just a kind of sedate him to stick it in once. It's sort of either repeatedly sedating them or keeping him sedated for several days or longer to see a response. And it might be it's going to take a couple of weeks for him to recover from this. So it's then difficult to work out what to do. What else could you do? What are the options for sedation in here? Think about it from the nurse's point of view.
Dolls.
Sorry?
Dolls to put on.
Yeah, okay, so we need a dolls here, but he's not asking to leave, but there is something about continuous sedation. So if we were to go down a sedate in order to treat him route, we would certainly need to put dolls in place. What we actually did is that he continued to deteriorate. This wasn't a stable thing, he wasn't getting better. He clearly lacked capacity, so there is a question, has he got capacity to make these decisions? No, he doesn't have capacity. He was awake, he was able to talk to us, but he didn't have capacity to decide any of it. So therefore we needed to make decisions in his best interest, and that was involving the family. We may need sedation in order to provide care, and his family were in agreement with that. So this was limited sedation in order to get him clean, because being in a dirty bed is sort of is undignified, and that was felt to be something that he wouldn't have wanted, wouldn't have appreciated. However, to sedate him in order to do further investigations and scans and treatment was felt to be kind of a step too far. So this is where this idea, if you come across the idea of the least restrictive option, if you're doing a best interest decision, you should think about choosing the least restrictive option. And I think that's often something we struggle with. I can't really work out where that sits and what that means. But in these circumstances, you could say that the least restrictive option is to provide basic care, but not to provide ongoing kind of medical treatment, scans and investigations, which may or may not lead us anywhere, or kind of to provide food and fluids when he's declining that. So that might be a more restrictive option, but at least restrictive one is let's get him cleaned up and sorted. It wasn't obvious to any of us really that investigating him, putting medications in of any sort, or food and fluids was going to be in his best interest, and that prolonged sedation that would be needed was not appropriate. So that's where we ended up with him. So we did provide sedation for basic care, basic nursing care and getting him clean. And he steadily deteriorated and died within a week. So the steroids wouldn't have helped because he died within a short period, and they wouldn't have been able to turn that around. He only needed sedation the once, because once he realised that the nurses were going to clean him up, get him sorted, and then he was all right, he didn't actually object to it anymore. He still didn't eat and drink, didn't want to, but he did allow basic nursing care. It might have been he was getting more cooperative, it might have been actually he was less well and he couldn't really object in quite the same way, but they only needed to do it the once. But it's an interesting kind of process, and that idea of the least restrictive option coming in there. Okay, another one is an 83-year-old man with heart failure and a recent MI, admitted for 4 days with shortness of breath, chest pain and general deterioration, already on maximum medical treatment. So again, that's a poor prognostic feature when you see that somebody is already on maximum treatment they come in, and you can't think of anything else to add to the concoction of drugs that they're already on. It was agreed with the patient and daughter for discharge back to his nursing home. So he came in from a nursing home and he didn't want readmission, and that was all well documented in the medical notes. What do we need to do to plan his discharge?
To communicate that clearly to the nursing home
Okay, how?
and then to let the GP aware.
Okay, so communicate it clearly with the nursing home. How? How are you
Advance
gonna do
directive.
that?
Do an advance directive.
Okay, so an advance directive is an advance decision to refuse treatment, is the term for that. And you need to have capacity to do that. So there's a question about whether he's got capacity to do that. But actually, is this about what he wants, or is this about us sort of making a sort of best interest decision with him? And so there's all of that coming into that. But no, probably an advanced decision to refuse treatment is a bit more involved. That's the one that you do with a solicitor, really, and get it clearly documented and signed. So what else would you use?
Make sure he has anticipated medications.
Yeah, okay, so you make sure he's got medications to manage him at home. I'm really desperate that somebody's going to say respect form. Okay, so this is where your respect form comes in, documenting your wishes, and particularly about readmission to hospital. We're clear here what he wants, what he doesn't want, what's the appropriate treatment for him. So we need to make sure that that is clear. The other thing you can do is phone them. You know, either you or the nursing staff, but somebody can phone the care home and make sure that they understand and go through that. They've sent him in and we're sending him back. If we don't make it clear, they'll send him back in again. So many respect forms just say for DNACPR, ward-based care. Nursing home will see that and go, all right, so ward-based care is the ceiling of treatment. I better send him back to the ward then because he's deteriorating. And we've had discussions, we've said that we're not going to treat any further, we're going to discharge him out for end-of-life care, we're not communicating it. So we need to communicate it. Okay, he was discharged back to the nursing home. And the EDD, this was slightly before a respect form, so there wasn't a respect form to fill in these cases, but that's where we would go now. The EDD stated for GSF. No other communication with the community, no phone calls or anything like that. No anticipatory prescribing, so you're right to pick that up. Okay, so what does for GSF mean? Never heard of it. Okay, so that means, does anybody online know what that means?
Is it a gold standard framework?
Okay, so what does it mean when we're telling the GP that they're for the GSF? What does it mean?
Yeah, I think it's an advanced community care and support plan for people with dementia, I believe. I'm not too certain about the full details of it, but I believe that's what it's commonly
Okay.
for people with dementia.
So it's not specific to dementia, it is for people, it means gold standards framework, and it's for palliative patients. So patients who are in the last year of life might be put on the GP's GSF register or palliative care register, which means it's a list of patients that they've got on their caseload who are palliative, and therefore we need to make sure that they are regularly reviewed and have the support and care that they need. So what it means is the GP will see that and say, right, I'll put them on the list. We've got a meeting coming up next month and we'll discuss them. They have monthly or sometimes bi-monthly meetings to go through the caseload and make sure that everybody's got everything in place that they need. What it doesn't mean, which is what the person who wrote this meant, it doesn't mean don't send them back into hospital. It doesn't mean palliative end-of-life care, not for readmission. But they were writing that as a code, meaning not for readmission, and the GP was looking at it and saying, that's not a code that I recognise. That means put them on a register. So we've got to be really clear when we communicate what we actually mean. And we've now got a respect form in place, which is the ideal place to write this. But what we need to be writing isn't ward-based care, not for escalation. It's not even keep comfortable, because are you more comfortable on IV antibiotics? Possibly, you might need to come back into hospital for those. So you need to be really clear on what treatments you will and won't offer. And here, their wishes for end-of-life care were already explored, but we haven't told anybody properly. So we need to be really clear when we are making these decisions what we actually need. Okay, what happened is he was readmitted to hospital 3 days later. GP hasn't even looked at the EDD yet. The fact that it says for GSF on it doesn't mean don't send them back in. They were dismayed that this patient was sent back into hospital, as in the team that are looking after them, but they hadn't actually communicated to the GP that that wasn't the plan. So they were blaming the community, and the community, quite rightly, was saying, well, we don't know that, you've not told us. So he came in with a BM of 1.4, chest pain, hypotensive, losing consciousness, some ST elevation on the ECG that people got excited about, but it was there from previous because he'd had a cardiac event not long ago. Does he need to be in hospital?
No.
What do you reckon? Yes or no?
No.
Okay. Essentially, it depends on what the patient's wishes were and what there is here that's reversible. There are some potentially reversible issues. We've got his BM is very low. We could do something about that. It's hypotensive. We might be able to do something about that. He may be septic. This may be another cardiac issue, and we may be able to do something about it. But underlying all of that, he's deteriorating, he's approaching the end of life, he doesn't want it, he's already said he didn't want to come back in. So this isn't the right place for him to be, but he's back in because we didn't communicate that properly, okay? So we have some responsibility for it. What happened in his case was he had some bloods done, he had a troponin, which was a bit raised, as you'd expect. He had some blood gases, he had a chest X-ray. He had urine sent off for Legionella and pneumococcal antigen. He had blood cultures and a sputum culture. He had a urine culture. He had a bladder scan. He had a catheter put in, had fluid balance done. We monitored his BM. We gave him IV antibiotics. We gave him IV fluids. He was cold, so we put him on a bear hugger. We discussed with Lincoln whether or not he should go for primary coronary intervention. And then the consultant wrote in the notes that this was an unnecessary admission to the hospital. We're not telling him that this is an unnecessary admission to hospital when we've done 16 hospital-based interventions before we make that decision. So that's really unfair because there's a lot of criticism going towards the community here. Why did they send this person back in? What on earth has he come here for? We've got nothing to offer. They've done all of this and then said that he shouldn't have been here. And the reason he came back in is because we didn't tell them that they shouldn't have been here in the first place. So we have to take responsibility for these things. So it's really important when we're discussing these sorts of patients that we're clear on what we're expecting and why somebody may or may not be appropriate to come back in. He was discharged back to the nursing home for end-of-life care, but we made it clear this time that was the situation that we came in. But that is a horrible thing to go through when we essentially, at the end of it all, didn't do anything and we had nothing to offer. But we put him through all of that. Coming into hospital is a really aggressive thing to do to somebody who's dying if there isn't anything for us to offer. Can I just check that the next consultant isn't online ready to teach? Is there anybody there to take over? So I can carry on for as long as we've got available.
I think he comes in person, yeah.
Okay, right, fine. In that case, I'll carry on to the next case and we'll stop as and when he arrives. If anybody is online and wants to take over, then do just give me a shout. Okay, so we've got a 76-year-old chap with motor neuron disease. Lives with his wife, his son is nearby, and he had several months of investigation prior to the diagnosis, as is fairly common with MND. And he was finally diagnosed a year ago. So he's been through a long process to get to this point, and now he's got a diagnosis. Since then, he's steadily deteriorated. He's lost mobility, he's lost functional status, starting to have difficulty swallowing, which is always a bad sign in MND. Recurrent hospital admissions. So again, one of your prognostic features is how often have they been in hospital? If it's, sort of 4 times already this year, with shorter periods of being at home before he comes back in again, that's a sign that that time is getting short. He's got respiratory muscle weakness, so he's increasingly dependent on non-invasive ventilation. So if you're not sure about that, non-invasive ventilation, the NIPI machine, people often become hypoxic, but also hypercapnic overnight because you don't breathe as much overnight. And if your breathing is already compromised, you start to develop CO2 retention and wake up with headaches and feeling drowsy and groggy in the morning, slowly recover over the day, but then sort of waking up again ill the next morning. So people start with non-invasive ventilation overnight just to give them some respiratory support. What then happens is as they get weaker and weaker, they're extending the period that they're on non-invasive ventilation. They end up sort of on it sort of for periods during the day as well. They're getting more breathless, so they put it on again, and they end up in a position where they're NIPI dependent and on it all the time. And then people are sometimes left with the difficult decision as to whether they want that to carry on or actually I never wanted this in the first place and do I want to stop it. So we're asked to speak to him about DNACPR. He was asked if he wanted to be resuscitated, and he said yes, please. Because we shouldn't have asked him, because that isn't a fair question to ask somebody, and it's not informed consent if you've not done any of the informing bit beforehand. What you're doing is presenting somebody with an impossible kind of decision to make. Do you want to die? No, not really. Okay, and so you end up in a bit of a mess. He is able to communicate. He's got capacity, and he's able to communicate by writing. So it takes a little while, but you can talk to him. So, what's his prognosis? Anybody want to hazard a guess?
Poor prognosis.
Sorry, say again. Poor, did you say?
Poor prognosis.
Okay, can you put a bit more detail in that? How poor is poor?
He's dependent on he's depending upon for breathing permanently or non-invasive.
Yeah.
Respiratory muscle weakness. So, I mean, very poor prognosis.
Okay, are you able to quantify it at all?
Not sure regarding that.
Okay.
3 to 6 months.
Days,
Okay, so we have 3 to 6 months here.
few days.
A few days. Okay, big difference there. Weeks, right. So we've got anywhere between days, weeks, and months. I think that is the right way of phrasing it. I wouldn't say 3 to 6 because I don't think any of us are that accurate. So putting numbers on things is always difficult because you're almost bound to be wrong, and people will get cross with you whether you're wrong one way or the other. But what we can do is look back and see how quickly he's deteriorating and reflect that forward. So if he's deteriorating, maybe not day by day, but deteriorating over weeks. So you can see each week he's a bit worse than he was last week, which is probably where he's at. Then you can reflect that forward and say his prognosis is probably weeks. So of the 3 here, we have days, weeks, and months, I would go for probably weeks rather than months. And I would phrase it to him in that way if he was wanted me to go through it. I would talk about a prognosis of weeks. Would you leave him for CPR? Okay, what's the outcome from CPR?
For chance
For him specifically.
for successful and then for quality of life is successful.
Okay, so what's the outcome going to be for him?
Maybe I don't understand.
Okay, I'm asking you to predict the future. He deteriorates and dies,
Yes,
and you start doing CPR on him. What's the outcome most likely to be?
unsuccessful.
Okay, so it's either unsuccessful, or if it is successful, what's the outcome going to be?
Very poor quality of life. And most likely it's going to be tube dependent.
Yeah, so he's going to be stuck on a ventilator.
Yes,
So the best outcome here, if he dies, it's because of respiratory failure.
yes,
If he comes back again, his lungs aren't going to be better.
yeah.
So therefore, his outcome here is going to be, at best, that he is on a ventilator in ITU and can't get off it. And he will be ventilator dependent. So there is a question, first of all, is that what he sees his future as being? Is that what he wants? And secondly, is that something that we're prepared to offer? Would ITU take this chap?
No.
No. So what you're going to end up with is, at best, you get him back, which you might do because his heart's all right. So if he dies, you may be able to get him back, but you'll be there bagging him in the side room while the ITU consultant looks at you and goes, what on earth are you doing? I am not taking this chap to ITU. and then you have to decide, okay, at what point do I stop doing the, I'm sorry, you can't see me online, can you? I'm there holding a face mask on and doing the bag and deciding whether or not that we stop doing that, because at some point he can't breathe for himself. ITU aren't going to take him, so he's going to die in the side room. So we've brought him back just to let him die a few minutes later. Is probably the best outcome. The worst outcome isn't that he dies, it's that he gets hypoxic brain injury during all of this and then dies, but dies fitting and very distressed, which I've seen and is unpleasant and not what you would want somebody. Oh, I think that might be hopefully there. Do you want to invite him in? Just say sorry, I was waiting for him to arrive. Yeah, come on in. Sorry, I was just carrying on until you arrived. So we're going to see. We just haven't finished. That's fine. That's all right. I've got a number of cases, but I'm not sure how far we'd get. So you can carry on talking as long as you want to. I'll just finish this case and then I'll. It's all right. Okay. So yeah, the best outcome here is really that he dies and you're unsuccessful. The worst outcome is he dies, but he's fitting and he's agitated and distressed, and you're stood there in a side room, bagging in and having to decide to stop. So it's a really kind of unpleasant and unnecessary kind of end to his life. So we really don't want to be going down that route. So we need to have a discussion with him and ideally with his family as well as to kind of what is the outcome here, what's going to happen, and a sort of clear understanding of all of that. What else do you want to think about discussing in his case? We've already talked about some of these things.
We have to discuss what the plan is and when it deteriorates. When do we stop intervening?
Yeah.
Not necessarily have to go to a cardiac arrest and make the reversal. So when do you stop? So respiratory support at what level? Do you stop it just NIV, or do you stop it when it needs a tube and all that getting planned? Okay. Yeah. So we need to think about what are his views around ventilation. What are his views about the non-invasive ventilation that he's already got, and is becoming increasingly dependent on that? And is that something that he is wanting to carry on? Feeding options, we know that his swallow is deteriorating, so at some point we need to think about that. His preferred place of care, where does he want to be? He's in hospital, is that what he wants? Does he want to be in hospital, or would he want to be elsewhere? And then, so once you've done all of that, then the bit about CPR at the end of it is quite easy, because you already know he doesn't want this, this and this. So CPR kind of, that decision's almost made itself. So that's kind of the way I would progress through that discussion. And actually the respect form is written in a way that leads you through what's your diagnosis and your understanding of it, what decisions have been made already, what are your wishes, what's important to you, what do you want, what do you fear the most, what do you not want, what recommendations we're going to make about treatment, and then CPR is at the bottom. So you don't start with, do you want to be resuscitated? You start with the condition, your understanding, and lead through it bit by bit. And by the time you get to CPR, often for palliative patients, that bit is straightforward. You don't even have to kind of ask people's views on it. You can just say, because of all of that, clearly we're not going to be able to resuscitate you, and these are the reasons why. Okay, so in his case, he didn't want feeding tube. He was already discussed all of this at the MND clinic. Often the MND teams are very good at sort of active advanced planning around kind of, they know which way things are going to go, and they kind of plan ahead for all of these things. So he's already made the decision about feeding tube, got that in place, that's fine. He didn't want to go to ITU, and he doesn't want to be on a ventilator. And he's aware that if he ends up on a ventilator, he would not get off it. Okay. If you're interested, this is a chat with motor neuron disease who's deteriorated. He was happy to carry on with non-invasive ventilation at night to reduce the morning headaches that he'd been struggling with, but he was fearful of becoming more dependent on it during the day. And he's intelligent chap who's done his homework. He's read about patients who become nippy dependent and then decide to remove the mask at some point and die a few minutes later. I don't know if any of you have ever come across that or seen that, but we've been involved in a case just recently, and we've had several kind of cases over the last few years where people have specifically decided that they no longer want their non-invasive ventilation. They've become ventilator dependent, and they go through a process of
kind of chatting with family and all of that, and then they take the mask off, or we take the mask off for them, and they often die within an hour. So sometimes it takes a few minutes, sometimes it can take, you know, through to the next day. But people will decide to stop a medical treatment. So it's fine to stop a medical treatment, but deciding they no longer want it, and they kind of almost decide the time that they will then deteriorate and die from removing that. And there's various sort of protocols and things in place to help you lead through that. So if you ever get a situation like that, do let the palliative care team know, because we do have some experience of managing these things. Once we've gone through all of that, he didn't want resuscitation, and that was fairly clear. So it's a process. When you're talking about resuscitation, there's a clear process to go through in order to make sure that we're doing it properly. So what happened? He began to deteriorate over a few days, more shortness of breath, more respiratory secretions. The early discussion around respect and planning helped with the decision making. So we got him home. He wanted to stay at home. He agreed to have a trial of oral antibiotics because this may be a chest infection. So he did want some active treatment, and he would happily take those. And he'd take medications for breathlessness, so a bit of midazolam, a bit of morphine, that sort of thing. But he wanted to avoid non-invasive ventilation during the day. He didn't want to become dependent on it and then have to sort of take it off at some point in the future. So he knew where he wanted his line to be drawn. Didn't improve with antibiotics, and actually after a day or two he was struggling to swallow them, so he couldn't manage them. So they were stopped, and he died at home a further 2 days later. So actually you were right when you said days. It probably was more, sorry, you said days, didn't you? It was probably more days than weeks. I think what the information I gave you, I would have said weeks, and I think we probably did talk to him about weeks at the time. He got another chest infection, deteriorated quite quickly, and it was probably a number of days in the end. It wasn't 3 to 6 months, I'm afraid. It was a bit shorter than that. But his family are very grateful for the care that he got. Okay, right, I'm going to leave it there, and I'm going to hand over. So we've got everybody on there. Do you need me to log out? Have you got your stuff on here? So
There might be some questions.
Sorry?
There might be some questions.
I can certainly ask. Are there any questions? I appreciate we've covered a lot of ground in those cases so far. Any questions at all?
Yes, I have a case for, sorry, case for the gentleman refusing treatment. He subsequently became a bit either weaker or more cooperative, and then died a few days later.
Yeah.
Now, the reason from when he to rescue medicine, we did stop any further interventions of the life because he seemed to be agitated and refusing it.
Yeah.
We had determined a lack of capacity. But in a situation where he seemed either more cooperative or he became quite more open to the idea of having treatment done, either cooperative or is it not? Can we just have a further discussion and say we're at this point in time?
Yeah.
As we said, the possible causes of what might have caused might be something that might or might not be reversible, but we could try with steroids. At this point in time, it was possible to give those treatments. So we're revisiting it at the point in time and saying, let's make changes.
So I don't know whether those online can hear all of that clearly, but basically a question about the chap who was agitated and aggressive and refusing all treatment. If he stabilised and became more cooperative, would have been able to treat him. Yes, of course, you can always revisit these decisions. And if he was then able to agree to treatment, or we could get him through a scan, it would be appropriate to do so, perhaps. The outcome would have been the same, I suspect. I mean, you're saying if he got better, which that might be different. He didn't, he got worse and he died. But if he had sort of stabilised and got a bit better, then yes, absolutely, you can revisit all of these things. Whatever decisions you make, I mean, a respect form, for example, is only guidance. It's not set in stone. You're not legally obliged to follow it. It is guidance from me chatting to the chap and his family today, from what I know, as to what you tomorrow, when he deteriorates and then has a cardiac arrest or respiratory arrest or whatever, at that point, what would you then do? And I'm trying to guide you as to what I think you might want to do. Your decision is still your decision as to whether or not you ignore that and do it and actively treat, or whether you follow the things that are in there. You'd have to justify your decision if you went differently to what we'd advised, but it is guidance. So if the circumstances change, then absolutely you should change your, you should revisit the decisions that have been made. And in those circumstances, yes, for him, it may have been appropriate to start him on some steroids. to get a scan, to see what we're dealing with, to see if there's anything reversible there. He didn't, and that wasn't the outcome. But yes, absolutely, you're right. When the situation changes, you need to take a step back and reevaluate and change decisions. What I'm more concerned about as a palliative doctor is that it's the other way around, where you're actively treating, you're doing everything you can, may have been appropriate initially, but patients have been in for 3 weeks, they're getting worse rather than better, and nobody is taking a step back and saying, is this now appropriate? What should we be doing? Do we change tack? Do we look at anything different? And often we're not making those, let's stop doing this stuff and focus on quality of life decisions until the patient is moribund, at which case it's too late to move them. You can't get them out of hospital. They've had a kind of difficult time while they've been in, and then they die here. And we could have sort of made a decision earlier. So that's often the argument I'm making, but the opposite is also true. If somebody is more stable or improves, then absolutely we should take another look at that and think about whether or not we change decision. I think sometimes we do that too readily. So somebody who is for end of life care, we've stopped everything, we're keeping them comfortable, they don't die in 3 days, and so everybody and so it all gets restarted and then put back on a drip again. And think actually that's not. The situation hasn't markedly improved. It's just that they didn't die as quick as you're expecting. And so that question is then being asked, should we start things? People don't always die in 3 days. Sometimes, it will take a week, it'll take a fortnight. I've seen people who aren't eating, aren't drinking, are barely breathing and last for a fortnight. It can happen. Yeah, so sometimes it takes longer than you think. Any other questions from those online?
Sorry, I have a question. When patients go to hospice, does it always mean like they don't have to come back to hospital, or can that change when we
sent somebody from the hospital, from the hospice back to the hospital today?
We see a lot of patients overnight where they come from hospice back into the hospital, and usually the patient's confused. And
so partly it depends on which hospice. So in St Barnabas, that's a medically led, consultant-led unit. So we've made a decision this morning that somebody who was in the discharge lounge, wasn't here, it was in Lincoln, but they didn't look closely enough as to whether or not he had cord compression, and we've sent him back because we think he does. And he would be for active treatment, he's for further chemo, so he should be treated. And they sent him to us for rehab, and we took one look at him and said, actually, no, you've missed something here. So we sent him back. So we absolutely can refer people back to hospital. When you're talking about people, particularly here from the Butterfly, being sent back in, sometimes that's because there's a lack of clarity as to what the plan is and what we have to offer. So that's where the respect form comes in. If you're saying we're sending them to the hospice for end of life care, there is nothing more for the hospital to offer, or indeed, when we've spoken to him and his family, that's not what they want, then that needs to be documented. If you send them with a respect form that says ward-based care, they'll send them back when they deteriorate because they'll think that that's what you were wanting. Okay, so you just need to be really clear as to what you're trying to achieve. Okay, right, I'm going to draw it to a close because I'm aware that we've got another session coming in. So I'm going to log off. For those who are online, if you want to switch over, there's an endocrine link, isn't there? So if you want to switch over to the other link, then you'll find the session restarts on that one. Okay, I'm going to say goodbye. So thank you very much for your time. Appreciate your input.
Thank you.